know triple negative breast cancers are the more aggressive cancers, and we know they present much more in an advanced stage. We know stage by stage, triple negatives always have a poor prognosis. We talk to our patients in the adjuvant therapy that they relapse much more faster. And in the first 2 to 3 years, we see relapses, and that's why we try to treat them more aggressively. But by nature and by stage-wise, survival is always poorer for triple negatives compared to other breast cancers. Next, please. This is what I was mentioning. You have seen the overall survival in various stages, and it's always poorer in the triple negative segment compared to the other segments. Next, please. So there's a very big unmet need for the management of metastatic triple negative breast cancer. We kind of believe the survival has always been to the tune of 1 year, 1.5 years, and we have only various chemotherapies which have been used in different lines of therapies. We have used taxanes, we have used anthrax, we have used capecitabine, we have used combinations with platins and gemcitabine, but there is a big unmet need for targeted therapies or immunotherapies as therapeutic options in triple negative breast cancer. Next, please. So next, please. Next, please. So you can have this slide. Just a minute. Sorry, just a minute. Yeah. So there was always a thought that immunotherapy will work in the segment of triple negative breast cancers, and the reason for this was always because we had a biological understanding of triple negative breast cancers. So it was seen that in triple negative breast cancers we have a high presence of mutations. And if there is more mutations, there is more neoantigens. And if there's more neoantigens, the immune system may become active. Secondly, there were more expression of PD-L1 in the triple negative populations. And we have seen this from the TCGA Atlas also. There's high PD-L1 in triple negatives compared to the other breast groups. And we know if the PD-L1 is higher, there's a chance that by inhibiting the PD-L1 here, you will get a better response. And also there were studies which showed there is a higher T-cell infiltration in the triple negative population compared to the other breast cancer subtypes. So clearly, it is the presence of all these factors which kind of make triple negatives much more immunogenic and much more responsive to immunotherapy. Next, please. So there were studies which looked at immunotherapy in the triple negative breast cancer in the metastatic setting. It was initially done in late line settings where you talked about treating in the third line setting, and you saw the response rate was only 5%. But as you move the treatment up the ladder, when it was used as a first-line therapy, the response rate went up to 25%. So that's one thing unique about triple-negative breast cancers in immunotherapy. We keep saying, if you're using immunotherapy, it has to be up the ladder. If you use it later, there is possibly by the multiple cycles of chemo you use, there is an immune exhaustion which takes place. And if the T cells gets exhausted, then you may not get an immune response. And that's why possibly we were not getting very good responses when we were using it as second-line and third-line therapy. But when immunotherapy moved up the ladder, the response rate went up much higher from 5% to 25%. And also we started seeing that these responses could be very durable. So with this background and this biological understanding, Impassion 130 was the phase 3 trial which was designed looking at a phase 3 data of using immunotherapy in the first-line setting. Next, please. So what Impassion 130 was, it was a big phase 3 trial looking at combination of placebo with nab-paclitaxel versus nab-paclitaxel plus atezolizumab. And this is in the triple-negative first-line population. Now, as a trial, it took up all patients in the triple-negative setting. And these are patients who had not received any kind of a chemotherapy for the metastatic setting. And they could have received some chemo, but it had to be given more than 12 months before for the adjuvant setting. Now, this trial had certain stratification factors, and they were liver metastasis, prior taxane use, and one very important point was the PD-L1 expression status. Now, in this trial, because we are using atezolizumab, mark you, the PD-L1 is being done by SP142 assay. That's the Ventana assay where we look at TC and IC in other cancers. But what we learned in breast cancer, the TC, the tumor cell expression is not very important. It's the immune cell expression which is very important. So the IC greater than 1% positive for triple negative breast cancer is considered PD-L1 positive. So any IC greater than 1% is PD-L1 positive, and there was a stratification for PD-L1 positive versus negative. Now mark you, the dose of nab-paclitaxel here was 100 mg meter square, day 1, 8, 15, repeated every 28 days. And atezolizumab was kind of converted to a dose of 840 mg fixed dose on day 1 and 15. This was to kind of align the immunotherapy with the chemotherapy regime. The co-primary endpoints were PFS, looking at the whole population, and then looking at the PD-L1 population, and then the overall survival, looking at the intent to treat population and the overall survival population, and the PD-L1 population. Next, please. So this was the hierarchical analysis in the Impassion 130. Now this is very important because when we read into the Impassion 130, we will hear a lot of talks about it and a lot of pros and cons and criticisms. And this was one of the main intention of how to look at the data. A hierarchical analysis for this was planned that you would first look at the PFS in the whole population and then the PD-L1 population. If that was positive, then you would look at the overall survival in the whole population, that's the intent to treat population. And if that is positive, then you would look at the overall survival in the PD-L1 population. Next, please. This is the patient disposition. Kind of just one point about this slide was PD-L1 positive was seen in 40% of patients out of the total population by the SP142. So 40% of patients are IC at least 1+. And the second point was at least 60% of patients had received prior chemotherapy. It could either be a taxane or an anthracycline, but there were 60% patients with prior chemotherapy exposure in the adjuvant setting. So 40% patients were de novo metastatic. Next, please. This is the primary results, which we saw initially in 2018. This is the final analysis. What it showed was the PFS in the intent to treat population improved from 5.5 months to 7.2 months. So this was clearly significant. The hazards, you can see the p-value there, and the hazards are 0.8. Now, because this was positive, you look at the PD-L1 positive population. And if you see the PFS one in the PD-L1 population, again, 5 months to 7.5 months, statistically significant with a hazard of 0.6. Next, please. So if you look at the subgroups, we see the benefit was seen in all the subgroups, but you kind of start seeing the difference there. In the PD-L1 positive population, there's a clear significant improvement of PFS, and in the PD-L1 negative population, you do not see that benefit. Next, please. The response rates went up, though it was only numerically, it went up, but you got 10% CRs with using immunotherapy in the PD-L1 population. Next, please. So with this, we come to, next, please. With this, we come to this was updated overall PFS data, which we saw this year. PFS in the intent to treat population is significant, but we clearly see that the difference in PFS in the PD-L1 population is significant. In the PD-L1 negative population, we are not seeing a big difference. Next, please. This was the final overall survival analysis. We saw this data. We saw last year, there was an update, and this year we saw the final overall analysis presented. Now here's the point about this trial. The overall survival in the intent to treat population was numerically higher, but it did not meet statistical significance. Now, because it did not meet statistical significance, a formal analysis of the overall survival in the PD-L1 population could not be done. But an informal analysis was done, and what the informal analysis clearly showed was in the PD-L1 positive population, the overall survival improved by at least about 7 months. So if you put in the hazards, it's clearly significant, but it could not be analyzed formally. Also, what we saw in the PD-L1 negative population, there was really no benefit in the overall survival. So in the right side, if you look at the curves of the OS in the PD-L1 positive and negative population, you see a clear separation in the PD-L1 positive population. And in the PD-L1 negative population in the middle, you see both the curves sticking together. That's the PD-L1 negative population where we saw no difference at all. So what we are seeing, there's a clear improvement in the overall survival in the PD-L1 population, but this was an informal analysis because of the hierarchical design. Next, please. This was the OS subgroups. Again, we see the same thing. We have a clear benefit in the PD-L1 positive population, the IC greater than 1%, and in the less than 1%, there was no major benefit of adding immunotherapy. The rest of the subgroups, again, clearly showed there is a benefit even if your patients had been exposed prior to chemotherapy or not. Next, please. Next, please. Just a minute, just the previous slide, please. This is a recent analysis of trying to look at exposure of the number of cycles patient received, and this is becoming very important to discuss, because what will happen slowly is we have seen the next trial, the paclitaxel atezo combination, and we know that's a negative trial. So we kind of looked at what are the differences. So this is one of the differences. The one difference I mentioned earlier, in this trial, 40% patients were treatment naive. So 60% were chemo exposed. And the second difference was here, in this trial, the number of cycles which were exposed was what was being looked at also. So you actually looked at patients in the atezo arm got 7 cycles of chemotherapy, with which was more than the patients with the nab-paclitaxel alone. And this is different from the trial when you read the Impassion 131 data, which is looking at paclitaxel. Next, please. Overall safety, again, clearly what we learned from here is the safety is exactly the same. There's slightly increase in the numbers of the overall adverse events. But what we clearly saw, all the side effects which were happening were due to the chemotherapy. So it was basically the nab-paclitaxel chemotherapy side effects in both the arms. It was not that the immunotherapy was really adding any major side effect in them. Next, please. Next, please. These were the side effects. Again, you clearly can see visually that the side effects were almost the same in both the arms. Next, please. Next, please. There was another point I would like to make was immunotherapy related adverse events, which we always talk about. Now, we kind of keep worrying about IRAs developing when we add immunotherapy to this chemotherapy arm. But what this trial clearly showed, the immunotherapy side effects were really not at all significantly higher. We did see a little more hypothyroidism, but then again, there was no discontinuation for that. You hardly saw any more increase in hepatitis and pneumonitis. There were no grade 3 events at all. And the IRAs were exactly the same. So we did not have any worry of adding immunotherapy to the nab-paclitaxel arm. So to summarize, Impassion 131 was the first phase 3 study to demonstrate a benefit in combination to first-line chemotherapy. Mark you, the chemotherapy has to be atezo plus nab-paclitaxel. And this is the first therapy to cross the 2-year landmark OS benefit in the PD-L1 positive population. The overall response rates were also higher in the PD-L1 positive population, including there were at least 10% complete responses which were seen in that arm. What we see in the PD-L1 positive population, we are seeing that the overall survival benefits are consistent. What we saw in the first interim analysis, what we saw in the second interim analysis last year, and what we saw in the final analysis, which were shown in the ESMO this year. The hazard ratio was clearly 0.67. And though we keep saying it was not allowed to be analyzed, it is an informal analysis, but what we clearly see, there is a significant impact. In the final overall analysis, that is a median follow-up of 18.8 months, the OS difference in the intent to treat did not cross significance. So we know we cannot just offer it to all our patients saying this is a good drug. It is only the magnitude of benefit in the overall PD-L1 positive population is where we see the significant benefit. And there was a 7.5 month benefit, which in clinical practice is absolutely significant. I think a 7.5 benefit makes a big difference to this group of patients when you have limited options of treatment. And there were no new safety signals in this trial. And this has kind of made it a good drug for clinical usage in our first-line patients. We have all adapted to doing PD-L1 positive by SP140 in all our triple negative metastatic breast cancer patients. And yes, in our first-line setting, we offer this to our patients. There's a lot of debate after the new data set which has come from the IMPire 131 about paclitaxel not being significant, but we kind of understand the differences that there was more Dexona exposure, more steroid exposure because of the paclitaxel, and the data sets of the patients were slightly different. So for us, this is clearly an impactful clinical trial with applicability in clinical practice, and we have started using it in our patients if we get a SP142 IC positivity. With this, I thank you, everyone. I thank you for this opportunity.